Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about the staging of lung cancer. Now, it's important to understand the staging of lung cancer because the stage determines the kind of treatment that's going to be given. So, for early stages of lung cancer, when they are very small or have not spread to involve major structures in the chest or elsewhere in the body, they can be treated pretty easily by just resection. Just go in, take out the cancer, and then maybe you can do some neoadjuvant chemotherapy or radiotherapy, or adjuvant chemotherapy or radiotherapy. However, if it gets to a certain stage where it now starts involving other important structures, it can be termed unresectable. So for this discussion, we are going to be talking about the TNM staging. So to start off, a T0 or a T0 stage means no primary tumor is seen on imaging. So maybe cancer must have been determined by a sputum or cytology of a pleural tap or something. However, on imaging, you didn't see any tumor, so you give that a T0. Then TIS is carcinoma in situ. Irrespective of the size, it can be as large as football. Irrespective of the size, only after resection of the tumor can you make this determination. So this one is a pathological stage. So to make the understanding of the T section of the TNM stage a little more understandable, I look at it as not only looking at the size of the tumor, but also the characteristics of the tumor, the location, its aggressive behavior. So you will see that we have a size category to put it under a particular T stage, and other features that still fit it within that same T stage. So for T1, for instance, under the size category, any tumor that is less than 3 centimeters is a T1 tumor. Now, it has been figured out that for every 1 centimeter increase in size up to 5 centimeters, there is a proportional decline in survival. So for T1 tumors that are less than 3 centimeters, they've been subclassified into T1A, T1B, T1C with 1 centimeter increments. So less than 1 centimeter is a T1A tumor, less than 2 centimeters but more than 1 centimeter is a T1B, and more than 2 centimeters but less than 3 centimeters is a T1C tumor. That's for the size. Now for the behavior, the tumor has to be surrounded by lung or visceral pleura. So this image shows a typical T1 tumor in the left lower lobe, completely surrounded by pulmonary parenchyma. The size characteristics of T2 tumors are to range between 3 centimeters and 5 centimeters, and these ones would show local invasion. So again, I try to understand the progression of the behavioral characteristics of these tumors based on the T classification on a predictable progression. So initially in T1, surrounded by lung parenchyma, not invading anything, not invading the visceral pleura. In T2, now we have local invasion of the visceral pleura and it's extending into the bronchi. So you realize that there's kind of a predictable progression and it makes sense. So T2 would be more than 3 centimeters but less than 5 centimeters. And again, just as the prognostic value of every 1 centimeter increase in size is significant, T2A would be between 3 and 4 centimeters and T2B would be between 4 and 5 centimeters. You realize it's increasing by 1 centimeter predictably. So in these images, this shows a typical T2 tumor with atelectasis. You can see there's a left lower lobe collapse, complete left lower lobe collapse, which is as a result of endobronchial spread of a left bronchogenic carcinoma. So this is a classic T2 tumor. Then T3 tumors, again, we are still increasing gradually, but this time it's from 5 to 7. So the numbers to remember: up to 3 centimeters for T1, between 3 and 5 for T2, up to 7 centimeters for T3. So the numbers to remember are 3, 5, and 7. Less than 3 centimeters for T1, between 3 and 5 for T2, between 5 and 7 for T3, more than 7 for T4. 3, 5, 7. That's for the size. Now for the behavior of T3. So this time round, it's not only involving or invading the visceral pleura, but it's going beyond the visceral pleura to invade the chest wall. If we go more medially, it's going to now invade the pericardium and then the phrenic nerve, which runs along the pericardium. Now, if you also have a metastatic nodule in the same lobe, a satellite nodule in the same lobe, that also upgrades it to a T3. So those are the behavioral characteristics. Again, it looks like it's following a progression. In T1, it didn't invade anything. T2 invades the visceral pleura, and the main bronchite hasn't reached the mediastinum yet. In T3, it now goes a little more medially to invade the pericardium, and if it's going more laterally, it's going to invade the chest wall. More predictable progression, and it makes sense. Also, we mentioned in the previous video that a pancreas tumor or a superior sulcus tumor automatically is a T3 tumor. So in this image, we see a typical T3 tumor in the right upper lobe with invasion of the chest wall. You can see a little bit of the tumor extending beyond the ribs to involve the soft tissue of the chest wall. Now, still moving forward, T4 goes beyond 7 centimeters. So 3, 5, 7. And behaviorally, going more medially, a T4 tumor would invade not only the pericardium, but now the mediastinum in general. You know, the mediastinum has so many structures: the heart, the great vessels, recurrent laryngeal nerve, the esophagus, and posteriorly, once the spine is also involved, it's also considered a T4 tumor. Now, if you have another nodule in a different lobe, this time not in the same lobe, that's jumped from, let's say, the upper lobe to the lower lobe, it upgrades it to a T4 regardless of the size. So in this image, we see a typical T4 tumor in the right upper lobe with invasion of the mediastinum. You can see this structure. There's a loss of a distinct plane between the tumor and the structures of the mediastinum here. So for the nodal classification, it's important to be aware of the distribution of lymph nodes within the chest. So we have hilar lymph nodes, mediastinal lymph nodes, supraclavicular lymph nodes. This presentation is not aimed at going through the various groups of hilar and mediastinal lymph nodes, but just to help us know at what point what nodal classification is given. So if you have a left-sided mass, hilar lymph nodes on the same side are considered N1. If you have metastasis into ipsilateral mediastinal lymph nodes, that's the yellow ones, ipsilateral mediastinal lymph nodes, that puts it at N2. And then when you have contralateral metastasis and supraclavicular lymphadenopathy, malignant lymphadenopathy, then that puts it at N3. Now for metastasis, if there is no metastatic disease, it's M0 or M0, and if there is metastasis, it's M1. Now the M1 is subclassified into M1A, M1B, and M1C. If it's only local thoracic metastasis, it's M1A. If it's a single extrathoracic metastasis, including a single non-regional lymph node outside the thorax, it's M1B. And if you have multiple extrathoracic metastasis in one or more organs, it's considered M1C. So I hope this has been helpful. And that brings us to the end of our discussion on lung cancer. The next thing we'll talk about is pulmonary vascular disease. That's the next big topic. The subtopic we are going to be discussing is pulmonary embolism. If this has been helpful, give it a thumbs up, share with someone you think would appreciate it. Leave a comment if you have any questions. You can ask if you have any inputs, something I may have left out, something I may have misstated. Kindly feel free to let me know in the comments, and I will see you in the next one.